Imagine being, I don't know, 22 years old. You're just starting your career, maybe you're thinking about grad school, just trying to figure out your place in the world.
Yeah, your whole life is ahead of you.
Right. And suddenly, your doctor sits you down and tells you that, well, you're going through menopause.
Which is just, I mean, it's unthinkable at that age.
Exactly. Your ovaries have stopped working. That biological timeline you assumed you had, the one that comfortably stretches into your late 40s or 50s, has just vanished. Welcome to the Deep Dive. If you're listening today, we're taking you into a diagnostic landscape that completely shatters our expectations of how the human body ages.
It really does.
We're exploring premature ovarian insufficiency, or POI. And our mission today is pretty straightforward, but honestly, incredibly profound. What exactly is premature menopause, and what are the underlying mechanisms causing it?
And we've compiled a really dense, fascinating stack of medical literature to figure that out. We're drawing heavily from the clinical guidelines of the European Society of Human Reproduction and Embryology.
Which, thankfully, we're just going to call ESHRE.
Yes, much easier to say. We've got the ESHRE guidelines alongside the NICE guidelines and the British Menopause Society. But we're also layering in some heavy clinical research on autoimmune endocrinology, plus practical patient insights from the NHS and the DAISY Network.
And the DAISY Network is a charity entirely dedicated to supporting individuals with this condition.
Exactly. Their on-the-ground perspective is so vital here.
Because whether you are navigating your own hormonal health right now, or maybe you're supporting a partner, or you're just intensely curious about the hidden mechanisms of the human body, you need this information. We are going to completely dismantle the idea that menopause is just a midlife event.
Right.
We'll explore the surprising triggers ranging from genetics to your own immune system turning against you, and look at why getting a fast diagnosis literally dictates the rest of a person's life.
So to really grasp the gravity of POI, I think we have to first look at the expected normal timeline of ovarian function. A natural menopause happens, on average, at age 51. And the medical community considers early menopause to be an end to ovarian function between ages 40 and 45. But premature ovarian insufficiency is categorized as a cessation of normal ovarian function before the age of 40.
And the prevalence statistics in the ESHRE guidelines completely upend the idea that this is some, incredibly rare anomaly.
Oh, absolutely. It affects up to 3.5% of women.
Wow.
And when you break that down by age, it impacts 1 in 100 women under 40, it's 1 in 1,000 under 30, and astonishingly, 1 in 10,000 under the age of 20.
We are talking about teenagers experiencing a severe systemic drop in estrogen, progesterone, and testosterone. That's wild to me.
It is. Which brings us to a really critical shift in how medicine even talks about this condition now. For decades, the standard terminology was premature menopause or premature ovarian failure.
Right.
But the consensus has moved firmly to premature ovarian insufficiency.
Because the word failure sounds so incredibly final, like a bridge collapsing.
Yes, exactly.
But reading through the research, the clinical picture is actually way more erratic than a sudden permanent stop.
That is the crucial distinction here. Failure, or menopause, implies a light switch was just flipped completely off and the wiring is dead. But the ovaries in POI don't always shut down permanently in one go.
They sputter, right?
Yes, they sputter. They have periods of intermittent activity. A woman might not have a cycle for 8 months and then out of nowhere have 2 normal cycles only for them to vanish again. The organ is acting insufficiently rather than being completely inert.
I picture it kind of like a sudden power outage in your house in the middle of the afternoon.
Yeah.
But the power lines aren't severed entirely. The grid is struggling, the lights might flicker on for a few hours, but the system overall is failing to provide enough electricity to keep the house running.
That's a great analogy.
So if we look at this as a localized power failure, the obvious question is, what is actually tripping the breaker?
And this is perhaps the most difficult reality for a patient to hear, because in about 90% of cases, POI is classified as idiopathic.
90%.
90. That means despite biopsies, blood tests, genetic screening, modern medicine simply cannot find the underlying trigger. The ovaries stop functioning, and we just do not know why.
The DAISY Network materials highlight how psychologically devastating that 90% statistic is. Human beings are wired to seek causality.
We want a reason.
Right. If a bone breaks, you know you fell off a bike. If your reproductive system halts at age 28, hearing a doctor say, "we just don't know," Makes it incredibly difficult to process the grief.
It leaves patients in a highly vulnerable state. However, in the remaining 10% of cases, we actually can identify the cause, and the mechanisms behind those causes are fascinating.
Okay, so let's get into the 10%.
The first category is iatrogenic, which just means it's a result of medical intervention, so chemotherapy, pelvic radiotherapy, or the surgical removal of the ovaries.
Which makes sense.
Right. And as childhood cancer survival rates have climbed past 80%, we're actually seeing a subsequent rise in iatrogenic POI as those survivors reach their 20s and 30s.
Oh, wow. I hadn't thought about that.
Yeah. Then the second major category is genetic.
Now, the sources specifically mention Turner syndrome and Fragile X syndrome. But the clinical texts just kind of list the names without explaining the biological domino effect. How does a genetic anomaly actually deplete an ovary of its eggs decades early?
Well, let's look at Turner syndrome first. Typically, ovarian function requires 2 healthy X chromosomes to properly maintain the supply of resting follicles. Those are the tiny sacs that hold the eggs.
Right, the storage units.
Exactly. In Turner syndrome, 1 X chromosome is completely missing or structurally altered. Without that complete genetic instruction manual, the cells surrounding the eggs undergo rapid apoptosis.
Apoptosis being programmed cell death.
Precisely. The biological machinery essentially triggers a self-destruct sequence in the follicles at a highly accelerated rate, so the supply just burns out before the woman even reaches adulthood.
That is heartbreaking. And Fragile X.
Fragile X syndrome operates differently. Women who are carriers of a premutation in the FMR1 gene, which is a gene crucial for brain development, often experience POI. In this case, the mutated gene produces a toxic RNA byproduct. This toxic RNA builds up in the ovarian tissue and fundamentally damages the follicles, leading to early depletion.
So in one scenario, the eggs are systematically deleted by a self-destruct code, and in the other, they're poisoned by a cellular byproduct.
Basically, yes.
That brings us to a cause that genuinely baffled me when reviewing our sources. Infections. The literature notes that illnesses like mumps, tuberculosis, or malaria can trigger POI.
Very rarely, but yes.
I understand a localized infection causing damage, but mumps, that's a viral illness that typically affects the salivary glands. How on earth does a virus in your jaw shut down your ovaries?
Well, the virus itself doesn't destroy the ovaries. Your own immune system does.
Wait, really?
Yeah, it's a phenomenon known as molecular mimicry. So when a virus like mumps enters the body, your immune system studies the antigens, the unique structural proteins on the surface of the virus, and it creates antibodies designed to seek out and destroy anything with that specific shape.
Okay, so the immune system takes a mugshot of the viral protein.
Yes, but here is where the error occurs. Sometimes those viral proteins look structurally identical to the natural enzymes found inside your own ovarian follicles.
Oh, no.
Specifically within the Polytica cells. The Polytica cells are the vital hormone factories that surround the egg. So the immune system clears the mumps virus, but those antibodies are still circulating.
Right.
They bump into the squamous cells, recognize the similar protein structure, and assume the virus has returned. The immune system cross-reacts and starts attacking the ovaries.
It's like a highly trained security guard being handed a blurry photo of a suspect, and they end up tackling an innocent bystander just because they happen to be wearing a jacket with the same pattern.
That is an excellent way to conceptualize it. The immune system is doing its job just with faulty targeting data. And this mechanism of molecular mimicry bleeds directly into the most prominent known cause of POI, which is autoimmunity.
Which accounts for what? A pretty significant chunk?
Yeah, autoimmune disease accounts for anywhere from 4% to 30% of these non-idiopathic cases.
And the clinical research on autoimmune endocrinology makes it clear that when the immune system starts attacking the ovaries, it's rarely an isolated incident, right?
Mm-hmm.
It often signals a broader system-wide rebellion.
Oh, absolutely. We frequently see autoimmune POI clustering with other autoimmune conditions, forming what endocrinologists call autoimmune polyglandular syndromes, or APS.
Okay.
This is a scenario where the immune system systematically targets multiple hormone-producing glands. And the most critical link highlighted in our sources is between POI and Addison's disease.
Addison's disease being primary adrenal insufficiency, where the adrenal glands, which sit on top of the kidneys, stop producing cortisol, the body's main stress hormone.
Exactly.
The numbers here are alarming. Up to 20% of patients with Addison's disease also develop POI and vice versa. Why are those two specific systems linked in this autoimmune crossfire?
It comes down to a highly specific target. The immune system isn't just blindly attacking the whole gland, it produces autoantibodies against very specific enzymes needed to manufacture hormones.
Okay, which enzyme?
In the case of the adrenal glands, you need an enzyme called 21-hydroxylase, often written as CYP21A2 in the literature, to synthesize cortisol and aldosterone. We find that women with autoimmune POI very frequently carry antibodies specifically designed to destroy 21-hydroxylase.
Okay, so let's break this down for the listener. If a young woman stops having her periods, goes to a clinic, and is diagnosed with POI, does she now have a ticking clock on her adrenal glands?
It means her medical team must be highly proactive. Finding one autoimmune endocrine disorder mandates screening for others.
Wow.
The timeline here is what saves lives. Detecting those 21-hydroxylase antibodies in the bloodstream can predict the onset of Addison's disease years, sometimes up to a decade before the adrenal glands actually fail.
So those antibodies basically act as a predictive early warning system. By finding them, a doctor knows the immune system is actively planning an attack on the adrenals, even if the adrenals are still functioning perfectly today.
Yes, and Addison's disease is notoriously stealthy. The early symptoms are just fatigue, salt cravings, maybe some skin hyperpigmentation.
Things you could brush off easily.
Right. But if an undiagnosed patient experiences a severe physical stressor, like a car accident or a bad infection, their body cannot produce the cortisol needed to manage the shock, leading to a fatal adrenal crisis. Screening POI patients for these antibodies gives doctors a massive head start to monitor cortisol levels and initiate treatment before a crisis ever occurs.
Which makes catching the POI itself incredibly vital. If identifying POI can literally predict and prevent a fatal adrenal crisis a decade down the line, diagnosing it quickly is paramount. But the sources outline a diagnostic process that sounds incredibly frustrating for patients.
It is an absolute maze for them. The primary diagnostic marker people think of is amenorrhea, which is the absence of periods for at least 4 months.
Right.
But the systemic symptoms are what actually drive patients to seek help. When the ovaries stop producing estrogen, the entire body reacts because estrogen receptors are located in almost every major organ system.
We usually just hear about hot flushes and night sweats. But reading the Daisy Network symptom lists, we're looking at severe vaginal dryness, causing painful intercourse, extreme fatigue, heart palpitations, and debilitating joint pain.
Yes, the joint pain is very common.
Plus profound cognitive disruptions. Women report severe anxiety, depression, brain fog, and memory loss.
And you can imagine, if a 28-year-old woman goes to her general practitioner complaining of exhaustion, brain fog, and irregular cycles, statistically she's frequently told she's just stressed, working too hard, or maybe experiencing early signs of a mood disorder.
The physical symptoms are entirely masked by the realities of modern life. Everyone is tired and stressed.
Exactly. This is why the biochemical blood test is the absolute anchor of the diagnosis. They test for follicle-stimulating hormone, or FSH.
Okay, FSH.
When the brain senses that estrogen levels are plummeting, the pituitary gland tries to force the ovaries to work harder by pumping out massive amounts of FSH. It's essentially the brain screaming at the ovaries to wake up.
So a very high FSH level in the blood indicates the ovaries are deaf to the signal.
Spot on. But reading the clinical guidelines reveals a fascinating discrepancy in how that FSH level is interpreted.
Oh, this part drove me crazy.
Right. So FSH is measured in international units per liter. To diagnose POI, the ESHRE guidelines state that a woman's FSH must be over 25.
Okay.
The doctor-patient clinical reference cites over 30, and the British Menopause Society requires it to be over 40, measured twice, 4 to 6 weeks apart.
That blew my mind.
Yeah.
It's like driving down a highway and seeing 3 different speed limits posted on the exact same stretch of road. If a patient gets her blood work back and her FSH is 32, the European guidelines say she has POI, but the British guidelines say she doesn't. How does a clinician navigate those contradictions?
It requires a physician to treat the patient sitting in front of them, not just the number on the lab report. Hormone levels are not static. They fluctuate continuously.
Right, because of the sputtering we talked about.
Exactly. Because the ovaries can sputter, an FSH level might be 45 1 week and 28 a month later. Those thresholds, 25, 30, 40, are diagnostic anchors, but they cannot be treated as impenetrable walls.
Because if a clinician adheres strictly to the over 40 rule, a woman with an FSH of 35 who is suffering from daily joint pain, severe brain fog, and hasn't seen a cycle in 6 months might be denied treatment.
Which is why self-advocacy is so critical. A doctor has to synthesize the blood work with the clinical presentation. Once that diagnosis is secured, regardless of which specific threshold was crossed, the conversation must pivot immediately to intervention.
Because the clock is ticking.
Yes, the medical consensus across all guidelines is unanimous. The long-term states of living without estrogen are incredibly dangerous.
Yeah, the statistics on cardiovascular health are terrifying. The sources state there's an 80% increased risk of mortality from coronary heart disease in women who experience menopause before the age of 40.
80%.
How does the absence of estrogen damage the heart so aggressively?
Well, estrogen is heavily cardioprotective. It acts directly on the inner lining of blood vessels, promoting the release of nitric oxide, which keeps the vessels flexible and dilated.
Oh, I see.
It also helps regulate cholesterol, keeping the bad LDL cholesterol low and the good HDL cholesterol high. When you strip estrogen away decades early, blood vessels become stiffer, plaque accumulates faster, and the cardiovascular system ages at a highly accelerated rate.
And it's not just the heart, right? The skeletal system faces a similar accelerated aging process. Women with POI experience rapid bone density loss, particularly in the first 4 to 5 years after ovarian function stops.
Yes, leading to early onset osteoporosis.
What is the mechanism there? Why do bones rely on a reproductive hormone?
It's because bone is living tissue. It's constantly being broken down by cells called osteoclasts and rebuilt by cells called osteoblasts.
Okay, osteoclasts break down, osteoblasts build up.
Right. Estrogen essentially puts the brakes on the osteoclasts, the demolition crew. When estrogen levels plummet, the osteoclasts go into overdrive. The rate of bone breakdown vastly outpaces the rate of bone building.
So bones just hollow out.
Yes, they become porous, brittle, and highly susceptible to fracture. Furthermore, prolonged estrogen deprivation in younger years is linked to a significantly increased risk of neurological decline and dementia later in life.
Wow. So treating POI isn't just about managing uncomfortable hot flushes. It is literally about preserving the structural integrity of a woman's skeleton, protecting her heart, and safeguarding her cognitive function.
Exactly.
And the mandated treatment for this is hormone replacement therapy, or HRT, or the combined oral contraceptive pill, up until the age of 51.
And alongside the hormones, lifestyle medicine is crucial. High calcium intake, vitamin D supplementation to aid that calcium absorption, and regular weight-bearing exercise to force the bones to strengthen themselves. But the hormone replacement is the non-negotiable cornerstone of treatment.
But this brings up a massive point of friction for patients. Whenever the acronym HRT is mentioned, alarm bells ring regarding breast cancer.
Yes, constantly.
The media has spent decades amplifying studies linking HRT to increased cancer risks.
Yeah.
If you are a 30-year-old newly diagnosed with POI, the idea of taking these hormones for the next 20 years sounds terrifying.
This is a pervasive and highly dangerous misconception that we must correct. The highly publicized breast cancer risks, primarily stemming from the Women's Health Initiative study back in 2002, were based on older, naturally menopausal women taking hormones in addition to what nature intended for their age group.
Okay.
They were extending their estrogen exposure beyond the natural timeline.
That context changes the entire risk profile.
Completely. A 30-year-old woman with POI is not extending her exposure. She is experiencing a deficit. She is merely replacing the hormones her body is physiologically expected to be producing at that exact moment. The clinical guidelines are explicit. The HRT breast cancer risks quoted for women over 50 do not apply to young women with POI. By avoiding HRT out of a misplaced fear of cancer, a young woman invites a near certainty of cardiovascular disease and osteoporosis.
She isn't adding fuel to a fire. She's just putting the power back on in a house that is supposed to be lit. The therapy is replacing a stolen baseline.
Exactly the right way to frame it.
So let's pull all these threads together. Premature ovarian insufficiency is a profound systemic hormonal deficit. Whether it's triggered by the accelerated cell death in Turner syndrome, the toxic RNA of Fragile X, the medical crossfire of chemotherapy, or a confused immune system attacking ovarian Latika cells instead of a mumps virus, the result is the same. The power grid sputters and fails decades before it should.
But the crucial takeaway from the ESHRE, NICE, and British Menopause Society guidelines is that we have backup generators. We know how to mitigate the damage. Prompt diagnosis and immediate hormone replacement therapy can successfully manage the severe risks to the heart, the bones, and the brain.
For you listening, knowledge is your shield. If you or someone you know is in their 20s or 30s and experiencing unexplained joint pain, severe brain fog, hot flushes, or missed menstrual cycles, do not accept stress as the final answer.
Please don't. Advocate for blood work.
Ask for an FSH test. Keep pushing until a clinician looks at the entire systemic picture, because catching it early changes the entire trajectory of your physical and cognitive future.
It truly is the difference between thriving and facing preventable, life-altering chronic conditions.
Before we wrap up, I want to leave you with one final fascinating detail buried in the medical texts. We discussed how POI is an insufficiency, a sputtering engine rather than a dead battery.
Right?
Because of that intermittent activity, even with a confirmed POI diagnosis and elevated FSH levels, there remains a 5% to 10% chance of a spontaneous natural pregnancy occurring.
Which is amazing. The immune system or the genetic anomaly hasn't necessarily destroyed every single follicle. Some are just dormant, hiding in the tissue.
It leaves you to wonder, if those resting follicles can spontaneously wake up against all odds, temporarily restoring the power grid entirely on their own, what microscopic secrets do they hold? If the body can occasionally flip the breaker back on by itself, could the future of endocrinology eventually figure out how to coax those dormant cells out of hiding permanently, reversing POI entirely?
It's an incredible thought.
It makes you realize that even in a systemic power outage, the dark might not be as permanent as we think.